real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. World where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion.
Good morning, ladies and gentlemen, esteemed colleagues and young doctors. Greetings and welcome to our distinguished webinar series, R.E.M, Resuscitation Essentials for Moonlighters, a tribute to a decade of excellence at the Academy of Emergency Sciences. As an accredited American Heart Association training partner for BLS, ACLS, and PALS, we have consistently upheld the belief that resuscitation is not merely a task, it is our unwavering calling. Our motto, resuscitation is our calling, education our passion, underscores our enduring commitment to the art of life-saving. The choice of the acronym R.E.M for this webinar is not by chance. It reflects a profound connection with scientific research, suggesting that REM sleep is when we most effectively consolidate learning and memory. Today, we gather to deepen our knowledge and enhance your resuscitation skills with the firm belief that the wisdom imparted here will translate into lives saved. This year-long webinar series is generously offered free of charge, our humble contribution to advancing the realm of resuscitation education. We are resolute in our mission to empower young doctors and healthcare professionals with the essential knowledge required for their arduous moonlighting shifts. We express our profound gratitude for your presence here today, and we invite you to embark on this journey of enlightenment with us. Together, let us strive for excellence, and remember, resuscitation is our calling, education our passion. It is with great anticipation that we look forward to collectively advancing our understanding and proficiency in resuscitation. It is with great pleasure that I introduce our speaker for today. Dr. Rodriguez took her BS Biology at the University of the Philippines, Baguio, and did her Doctor of Medicine at Far Eastern University Nicanor Reyes Medical Foundation. She specialized in emergency medicine at the Rizal Medical Center, where she served the department as its chief resident. Currently, she is an active consultant for Makati Medical Center and Rizal Medical Center, and an active BLS and ACLS instructor for the Academy of Emergency Sciences. Friends, let us all welcome our speaker for today, Catherine Rodriguez.
Thank you so much, Doc Pao. Let me just share my slides. Can everybody see my slides? Yes. All right. So, good morning, everyone. Thank you for that very kind introduction, Doc Pao. I would also like to thank the Academy of Emergency Sciences for giving me the opportunity to be one of the speakers for the Resuscitation Lecture Series in celebration of their 10th year anniversary. So this morning, I am tasked to share with everyone some uncommon resuscitation concepts and techniques. Hence, our lecture is entitled Out of the Box ACLS, Uncommon Strategies You Need to Know. So the outline of our discussion is as follows. Some of these concepts may be new to you, or some of you may have already heard of it or are already practicing these things. Nevertheless, may we all learn a thing or two from this presentation. So this diagram, thanks to AES, is the combined adult cardiac arrest algorithm as recommended by the American Heart Association based on the latest 2020 guideline. The flow of our discussion will be generally based on this flowchart. We will begin with the concepts and strategies on compression, followed by defibrillation, moving on to airway, and then to medications. So let's dive in to our first topic. We are all familiar with cardiopulmonary resuscitation or CPR, right? It utilizes both compressions and mouth-to-mouth ventilation for cardiac arrest and is a standard concept widely recommended by the American Heart Association as the approach for out-of-hospital cardiac arrest since its introduction in the 1960s. Cardiocerebral resuscitation, or CCR, is an alternative to cardiopulmonary resuscitation. Basically, it is chest compression without ventilation, or simply hands-only CPR. This concept has been introduced to address the low survival rates of out-of-hospital cardiac arrest found out to be due to lack of bystander-initiated basic CPR due to the reluctance in providing mouth-to-mouth resuscitation on strangers. A survey done by the University of Arizona Server Heart Center CPR research groups revealed that only 15% of lay individuals, as well as certified CPR instructors and physicians, would definitely do mouth-to-mouth resuscitation on a stranger. This information led the CPR research group to ask whether chest compression only CCR without mouth-to-mouth rescue breathing was better for out-of-hospital cardiac arrest than doing nothing at all. So the University of Arizona CPR Research Group has published 6 studies with a total of 169 swine subjects and found out that chest compression only CCR and ideal standard CPR resulted in a similar 24 or 48-hour normal or near normal neurologic survival, and that both were dramatically better than simulated no CPR at all, as shown in this figure. Others have also confirmed these findings, such as the systematic review done by Yang and his team in 2010. 13 studies comprising of 3 randomized controlled trials and 10 observational studies were included. Its objective was to evaluate the efficacy of cardiocerebral resuscitation or CCR versus cardiopulmonary resuscitation or CPR for patients with out-of-hospital cardiac arrest. This figure lifted from the study is a forest plot showing the effect of CCR and CPR on survival to hospital discharge of post-cardiac arrest patients. Survival to hospital discharge, one of the outcomes analyzed in the study, was defined as the patient leaving the hospital alive or survival to 30 days post-cardiac arrest. The meta-analysis of 3 randomized controlled trials showed better outcome in the CCR group. However, the results of 7 cohort and 2 case control studies showed no significant difference between the two. Another figure from the study, this one showing the effect of CCR and CPR on survival with favorable neurologic outcome, which is a performance category score of 1 or 2. In this forest plot, both randomized controlled trials and observational studies favor CCR. The pooled result of 4 observational studies revealed that neurologically intact survival of patients with out-of-hospital cardiac arrest was significantly improved in CCR patients. In conclusion, the systematic review done by Yang et al. Demonstrates that bystander CCR might be superior to, or statistically speaking, not different from CPR for patients with out-of-hospital cardiac arrest in terms of survival. From the author's perspective, CCR is better than CPR in at least 2 main aspects. First is that CCR increases the willingness of bystanders to perform chest compression without the fear of contracting infectious disease from mouth-to-mouth ventilation. And second, CCR is more convenient to be taught and performed by the public. AHA acknowledges the compression-only CPR and promotes it since it is better than no attempt at CPR at all. The American Heart Association Emergency Cardiovascular Care Committee released a recommendation and a call to action for bystander response to adults who experience out-of-hospital sudden cardiac arrest. The AHA-ECC committee, aware of the relatively low prevalence of bystander CPR, is hopeful that further simplification of CPR instructions might encourage more bystanders to take appropriate action. Hence, the committee has concluded that adult victims of out-of-hospital cardiac arrest have a similar chance of survival if they receive hands-only CPR. Thus, bystanders can use either techniques, depending on your training and skills, to achieve the ultimate goal of saving lives. The AHA-ECC recommendation is as follows. When an adult suddenly collapses, trained or untrained bystanders should, at minimum, activate their emergency medical response system. and provide high-quality chest compressions by pushing hard and fast in the center of the chest, minimizing interruptions. So if a bystander, if an individual is not trained in CPR, then the bystander should provide hands-only CCR and continue until an AED is ready for use or EMS takes over. If a bystander was previously trained in CPR and is confident in his or ability to provide rescue breaths, then the bystander should provide either conventional CPR using a 30:2 compression to ventilation ratio or hands-only CCR until an AED is ready for use or EMS takes over. And if the bystander was previously trained in CPR but is not confident in his or her ability to provide CPR with rescue breaths, then the bystander should give hands-only CCR until an AED is ready for use or EMS takes over. That's it for our cardiocerebral resuscitation first topic. So we move on to heads-up CPR. During cardiac arrest, maintaining adequate cerebral perfusion pressure or CPP is key to increasing good neurologic outcomes. CPP is mean arterial pressure or MAP minus intracranial pressure or ICP. During cardiac arrest, CPP decreases dramatically, and active chest compression generates approximately 30% of pre-arrest cardiac output, and only 30% of that output goes to the brain. So additionally, conventional CPR increases vascular pressure in both the venous and arterial sides of the heart simultaneously, which in turn increases intrathoracic and intracranial pressure, which can impede cerebral blood flow and compromise coronary circulation. In theory, by elevating the head and chest, it allows for venous blood to drain from the brain to the heart, thereby decreasing intracranial pressure and increasing CPP or cerebral perfusion pressure. So in order for head-up CPR to work, we have to be able to effectively pump blood up to the brain, which is not typically achieved with conventional or supine CPR alone. Use of the active compression decompression device and impedance threshold device are one way to improve conventional CPR. So active compression device or ACD is a handheld suction device applied mid-sternum that compresses the chest, then actively decompresses it after each compression, while the impedance threshold device, or ITD, is a valve connected to a cuff tracheal tube. This device limits air entry into the lungs during chest recoil in between chest compressions, causing a decrease in intrathoracic pressure and an increase in venous return to the heart. So numerous research studies on animals have already confirmed that gradually elevating the head and chest with ACD and ITD devices can enhance coronary perfusion pressure, lower intracranial pressure, and improve cerebral perfusion pressure significantly while maintaining mean arterial pressure, as reported in a systematic review and meta-analysis by Wang and his team. The most important result of this study is that at head up at 30 degrees during CPR, it can significantly increase cerebral perfusion pressure, mainly by reducing ICP compared to supine CPR. So the reason for the lower ICP is that when elevating the head and body for up to 30 degrees during CPR, ICP will decrease by facilitating brain-venous return and CSF movement into the spinal subarachnoid space, which is consistent with other studies, even at different elevation angles from 10 degrees to 50 degrees. In addition, the reduction in ICP also decreases the resistance to forward brain blood flow, which is generated by each chest compression. So it was also found out that head up alone is not associated with a better outcome. So we have to use the ACD and ITD devices. It produces a markedly synergistic effect because both devices decrease intrathoracic pressure in the decompression phase, which leads to augmented venous return. Head up could also accelerate brain venous return by the gravity effect. Also, by using both devices, it is more effective in increasing cerebral perfusion pressure than head-up alone. In addition, it has been found that the priming step, which is CPR in the supine position for 2 minutes before elevating the head and chest, is important. So to date, a study on humans to confirm the clinical safety and feasibility of this bundled approach was done by Pepe and his team. It was a prospective observational study which revealed that the head-up cardiopulmonary resuscitation or CPR bundle was feasible and associated with an immediate steady rise in resuscitation rates during implementation, followed by a sustained doubling of the number of successful out-of-hospital cardiac arrest being resuscitated. So these findings make a compelling case that this bundled technique, head-up CPR with ACD and ITD devices, will improve out-of-hospital cardiac arrest outcomes. And now we move to the topic on defibrillation. So, brief interruptions in chest compressions reduce the efficacy of resuscitation from cardiac arrest. Interruptions of this type are inevitable during hands-off time periods for shock delivery to treat ventricular tachyarrhythmias. It has been well documented in several swine models that coronary perfusion pressure decreases with interruptions in chest compressions, and it takes several minutes of chest compressions to build up an adequate coronary perfusion pressure. So minimizing interruptions in chest compression is garnering increasing attention as a method to improve CPR quality and outcomes. And hands-on defibrillation has been suggested as a safe and effective means of reducing interruptions during chest compressions. So to counter these interruptions, the concept of hands-on defibrillation has been introduced. The safety of a rescuer remaining in contact with a patient during defibrillation has been the topic of a study by Lloyd and his team. In this study, they simulated conditions during resuscitation of cardiac arrest victims and measured the leakage voltage and current through mock rescuers while they were compressing the chest of 43 patients receiving external biphasic shocks, and in no cases were the shocks perceptible to the rescuer. During the shock, the rescuer's gloved hand was pressed onto the skin of the patient's anterior chest to simulate the worst case of an inadvertent return current pathway. A skin electrode on the rescuer's thigh was connected to an electrode on the patient's shoulder. The peak potential differences between the rescuer's wrist and thigh range from 0.28 to 14 volts. The average leakage current flowing through the rescuer's body for each phase of the shock waveform was 283 plus or minus 140 microamperes, which is below several recommended safety standards for leakage current. So the present findings of their study support the feasibility of uninterrupted chest compression during shock delivery, which may enhance the efficacy of defibrillation and cardiocerebral resuscitation. We use medical examination gloves when we perform defibrillation. However, the electrical characteristics of these gloves are unknown. So a study done by Sullivan et al. Examined the response of medical examination gloves to defibrillation voltages. Chloroprene, latex, nitrile, and vinyl gloves were tested, and all the gloves allowed little current to flow, less than 1 milliamperes, as the voltage was increased. However, once glove breakdown occurred, at that point, current flow increased precipitously. So in part 2 of the study, 45% of single gloves and 77% of double gloves allowed at least 0.1 milliamperes of current flow at voltages within external defibrillation voltage range. Meanwhile, 7.5% and 6.2% of double gloves allowed at least 10 milliamperes of current flow with external defibrillation. In conclusion, the study mentioned that few of the gloves tested limited the current to levels proven to be safe. In addition, according to the study, a lack of sensation during hands-on defibrillation does not guarantee that a safety margin exists. And as such, the authors of the study encourage rescuers to minimize rather than eliminate pauses to compressions for defibrillation. Now we move on to airway discussion. Between supraglottic airways and endotracheal intubation, which is the better technique? To answer that, let us first differentiate the two. So supraglottic airway devices are airway adjuncts used to provide patients with adequate ventilation and oxygenation. So these are inserted blindly without a laryngoscope or other means of directing the device into the airway, and they usually sit at the hypopharynx area. Supraglottic devices require less training and education to use than endotracheal intubation. There are many types of supraglottic airway devices on the market. The two common supraglottic devices are King laryngeal tube and the iGel. So the King laryngeal tube is a simple tube with an oropharyngeal and esophageal cuff. So between the cuff is an opening to allow air to travel to the larynx. The iGel, newer and growing in popularity, is a pre-shaped cuffless device made from a gel-like material. On the other hand, endotracheal intubation requires training for proper insertion during tube placement. The tube placement landmark is the vocal cords in the glottic opening. Tubes are placed by using either video laryngoscope or direct or manual laryngoscope. And there are two types of blade, the Miller and the Macintosh, that comes in different sizes for pediatric and adult patients. So the optimal approach to airway management during out-of-hospital cardiac arrest was the objective of two studies. The Airways 2 randomized clinical trial done by Benger and his team, and the Pragmatic Airway Resuscitation trial, or PART, by Wang and his team. In the Airways trial, paramedics were randomized 1:1 to use tracheal intubation and or supraglottic airway device, specifically iGel, as their initial advanced airway management strategy. So the primary outcome in the study was a modified Rankin scale score of 0 to 3, which is equivalent to good outcome at hospital discharge or 30 days after the cardiac arrest, whichever occurred sooner. The result, functional outcome, an MRS of 0 to 3 at discharge or 30 days after, in 6.4% of patients in the supraglottic airway group versus 6.8% in the tracheal intubation group. So in conclusion, in this study, the use of SGA did not provide a superior functional outcome among patients with out-of-hospital cardiac arrest. On the other hand, the PART study compared the effectiveness of initial laryngeal tube insertion versus initial endotracheal tube insertion in adults with out-of-hospital cardiac arrest. In this study, the primary outcome was 72-hour survival, which was found to be higher, 18.3% in the laryngeal tube group versus 15.4% in the endotracheal tube group. It was concluded that among adults with out-of-hospital cardiac arrest, a strategy of initial laryngeal tube insertion was significantly greater, 72-hour survival compared with the strategy of initial endotracheal tube insertion. So we are now on the part of medications. So the role of epinephrine in cardiac arrest, regardless of cardiac rhythm, has been recommended by the American Heart Association. It is an agonist at both the alpha and beta adrenergic receptors. The alpha effect causes peripheral vasoconstriction, which in turn leads to increased blood flow in the central circulation, improving perfusion of the heart and the brain. These effects are potentially beneficial and have been hypothesized to increase the likelihood of return of spontaneous circulation. The beta-adrenergic effect increased cardiac rate, contractility, and automaticity, and these effects are potentially deleterious, leading to arrhythmias and increased myocardial oxygen demand. And we all know that when intravenous or intraosseous access is available, epinephrine is given every 1 milligram every 3 to 5 minutes or every 4 minutes as a mid-range value. Each dose given by peripheral injection should be followed by a 20 ml flush of IV fluid to ensure delivery of the drug into the central compartment. But can we give epinephrine as a drip during cardiac arrest? So according to the American Heart Association Circulation Section 6 on Pharmacology, agents to optimize cardiac output and blood pressure, epinephrine may be administered by continuous infusion during cardiac arrest. The dose should be comparable to the standard IV dose of epinephrine, which is 1 milligram every 3 to 5 minutes. So the continuous infusion is accomplished by adding 1 milligram of epinephrine to 250 ml of normal saline or D5 water to run at 1 microgram per minute, increased to 3 to 4 micrograms per minute. So in continuous infusions of epinephrine should be administered by central venous access to reduce the risk of extravasation and to ensure good bioavailability. So two benefits can be acquired from the use of an epinephrine drip. First is cognitive offloading. With an epinephrine drip running, less brain work is used to time the dose of epinephrine every 3 to 5 minutes, and the team can now focus on other aspects of the code. Another benefit is avoidance of post-return of spontaneous circulation or post-ROSC drop in blood pressure. With conventional epinephrine dose, a drop in blood pressure is seen once epinephrine wears off. With an epidrip already running, the post-ROSC drop in blood pressure can be addressed easily and map goals easier to achieve. So the management of tachyarrhythmia is part and parcel of advanced cardiac life support. So supraventricular tachycardia or SVT is one of the most common tachyarrhythmias encountered in ACLS. Supraventricular tachycardias originate from a focus within or above the atrioventricular node and most often present with a narrow QRS complex of normal with rapid and regular, and P waves are absent or buried within the QRS complex in about 70% of cases, with the ventricular rate usually 170 to 180 beats per minute. So therapies for SVT include physical treatment, pharmacologic management, and electrical therapy, and largely depends on the patient's hemodynamic stability. So the Valsalva maneuver is an effective vagal maneuver and is a recommended first-line physical treatment for patients with SVT. However, it is performed inconsistently and has a relatively low, about 5 to 20% cardioversion success rate in clinical practice. Hence, a modification of the standard Valsalva maneuver has been the focus of the randomized evaluation of modified Valsalva effectiveness in reentrant tachycardia or the REVERT study, which compared the standard Valsalva maneuver with a modified Valsalva technique in terms of its ability to convert an SVT into a sinus rhythm on a 12-lead ECG. So, standard Valsalva is performed either lying flat or seated at a 45-degree angle and then straining for 15 seconds while remaining in this seated position or in the either lying flat or seated for 60 seconds. In contrast, the modified Valsalva is performed while seated at a 45-degree angle and then performing a standardized strain for 15 seconds to a pressure of 40 millimeter mercury or by blowing into a 10 ml syringe to move the plunger generates the similar pressure. After this, the patient will be laid flat and legs will be raised to a 45-degree angle for 15 seconds and then return to the 45-degree semi-recumbent position for 45 seconds. So, 43% of 214 participants in the modified Valsalva maneuver group versus 17% of the participants in the standard Valsalva maneuver group achieved the primary outcome of sinus rhythm at 1 minute. The use of adenosine was significantly lower in the modified Valsalva group than in the standard Valsalva group. So the REVERT study has shown that a simple, cost-free, well-tolerated postural modification to the standard Valsalva is highly effective, converting more than 40% of patients to sinus rhythm compared with the standard Valsalva. This difference resulted in a substantial reduction in the number of patients needing other emergency treatments, particularly adenosine. However, if SVT does not respond to Valsalva maneuver, the first-line pharmacologic treatment is adenosine. Adenosine is an endogenous purine nucleoside that blocks atrioventricular nodal conduction. It has a rapid onset and a half-life of less than 10 seconds. So standard dose via the peripheral intravenous route is 6 milligrams, followed by 12 milligrams if the first dose is ineffective. To achieve effective rhythm conversion, IV administration should be followed by a rapid 20 ml saline flush through a large vein, especially usually we use the antecubital vein within 1 to 2 seconds. This conventional method of adenosine administration is called the double syringe technique. This method generally requires an IV line and a three-way stopcock in 2 syringes. Furthermore, at least 2 staff are needed to administer the adenosine and NSS simultaneously to ensure effectiveness. So the use of single syringe technique, wherein adenosine is mixed with normal saline up to 15 to 20 ml and administered intravenously, has been studied by Kotrushin and his team among other researchers. The study was a pilot, multi-center, single-blind, randomized controlled study with 30 patients included in the final analysis. So compared with the double syringe technique, this intervention allows only one nursing staff to perform this procedure. It is easier because it does not require additional materials such as a second syringe and a three-way stopcock. So in their study, the termination rate of SVT was 93.3% in the double syringe technique and 100% in the single syringe technique. And the success rate of the first 6 milligram dose of adenosine was higher in the single syringe group. In conclusion, adenosine diluted with up to 20 ml of normal saline administered intravenously using a single syringe was non-inferior to the conventional technique of using double syringe for terminating SVT. The single syringe technique was also practical and safe. However, this is a small scale study, and a further definitive study with a larger sample size is recommended by the researchers. And last but not the least on our outline, the term torsade de points or twisting of the points was coined by a French cardiologist, François de Certain, in 1966 to describe its ECG appearance. So it is a characteristic polymorphic ventricular tachycardia with QT prolongation of more than 500 milliseconds is considered highly abnormal for both males and females. This uncommon arrhythmia characteristically occurs in self-terminating bursts, causing dizziness or syncope, and occasionally seizures, but can occasionally degenerate into ventricular fibrillation, resulting in sudden cardiac death. Prolongation of the QT interval can be congenital or acquired. Acquired long QT is caused by heart diseases, electrolyte abnormalities, and/or exposure to precipitating medications, of which a large number of medications has been implicated, such as in the table on the right side of the screen. These drugs usually delay cardiac repolarization by blocking relevant potassium channels. The American College of Cardiology, American Heart Association, and European Society for Cardiology recommends the following for the management of torsades. Responsible agents or QT prolonging drugs should be discontinued, and modifiable risk factors such as hypokalemia, hypomagnesemia, and hypoxia should be addressed. Other therapies include IV antiarrhythmics, electrical cardioversion, and transvenous pacing. And the recommended first-line agent to terminate torsades is magnesium sulfate, regardless of magnesium level. So the recommended dose according to the American Heart Association is as follows. So for cardiac arrest due to hypomagnesemia or torsade, magnesium sulfate, the dose, the intravenous or intraosseous dose is 1 to 2 grams, which can be 1 to 2 grams infused IV or intraosseously. For patients with torsade with a pulse or acute myocardial infarction with hypomagnesemia, an IV loading dose of 1 to 2 grams mixed in 50 to 100 ml of D5 water or normalized saline is given over 5 to 60 minutes, followed by a continuous IV infusion. So this is the end of my presentation. This is my last slide. So thank you for listening, and let me end my presentation with a quote from Mahatma Gandhi. Live as if you were to die tomorrow, and learn as if you were to live forever. Thank you very much. And I'm turning over the microphone to Doc Pao.
Thank you, Doc Katie. That was a very interesting, very comprehensive discussion of cutting-edge ACLS strategies, and we really learned a lot from the lecture. So I'll now open the Zoom chat, no, and the YouTube live chat, no, for any questions that the participants may have for our speaker. So thank you once again, Doc Katie. We already have a question in the chat room, no? So from Rose, Doc, tanong ko lang po kung okay pa rin ba magbigay ng NSS 250 ml pag nag-cardiac arrest yung patient ko na may CKD.
Sorry, Doc. Can you repeat? Nag-choppy
Right.
po.
So the question from Rose is, okay lang ba magbigay ng NSS 250 ml sa cardiac arrest patients na may CKD?
NSS 200 ml, Doc.
250 ml pag nag-cardiac arrest. So I guess parang during cardiac arrest, you'll bolus 250 ml in a patient with CKD if that practice is okay. So I think maybe in their setup is they push 250 ml of NSS during cardiac arrest. So she's wondering if that's okay to do for CKD patients.
Actually, for cardiac arrest patients, importantly, our priority is chest compression. And then we have to know if the patient should be amenable to defibrillation if yung rhythm natin. So we have to know first if the rhythm is shockable, no? And then we can give the medications. Actually, the giving of fluids comes in later na, no? Lalo na we have to, important dito kasi yung causes, yung ating causes of the arrest. So if mukhang dry yung patient natin na may CKD, then I think it's okay to give fluid bolus. But if mukha kasing congested yung patient natin, I think giving fluid bolus will be more harmful. So in conclusion, giving of fluids, it will depend on the case, on the history taking that we will get from the companion of the patient with ongoing cardiac arrest. Do you agree, Doc Pao?
Yeah, totally agree. All right. So I still have some questions here, Doc, if you don't mind. So from John, good day, Doc. Are these recommendations already practiced here in the Philippines or still on current study, like the head-up CPR and modified Valsalva? Thank you, Doc.
Thank you. Thank you for the question. So the head of CPR, based from my research, is I haven't found a study done here in the Philippines. Actually, I think it's because it requires newer devices yung ACD and ITD. But the modified Valsalva, yes, it's already being practiced. Kasi actually, it's just a postural modification from the standard Valsalva. So yes, modified is already practiced, but the head up CPR, I haven't read any studies done here in the Philippines.
Doc, I hope you don't mind at sunod-sunod ang mga tanong. Ang dami. Alright. Doc, may question pa tayo from Joselito. Doc, ask ko lang about CSM in SVT. So I think he's asking kung ginagawa pa ba? Is it still successful? So I think CSM is carotid sinus massage. I hope I tama yung interpretation ko nito, Mr. Joselito. So What are your thoughts on carotid sinus massage on SVT?
Yes, I think carotid sinus massage is still being practiced naman. Actually, nandun pa din siya sa list ng vagal maneuvers natin. But we have to always remember before we do carotid sinus massage na we have to check if may bluey yung patient. Although, ang problem lang with that is yung low conversion rates, no? You can really, it does not really it has a low conversion rate, no, SVT to normal sinus rhythm. Pero if the question is ginagamit pa ba? Yes, I think still there are physicians who still start with carotid sinus massage.
Thank you, Doc. Another question from Cyrus here. And we appreciate all your questions, guys. No, thank you for your active participation. So Cyrus is asking, ask lang po ako, how do you assess if there is ventricular tachycardia or none without interrupting chest compressions? Because chest compressions distorts the ECG tracing.
Yes. So actually, during chest compression, we have a time naman yung ating code, no? So we do chest compressions for 2 minutes, and then we have a specific time wherein we have to check the rhythm. So during that time, then we will know if kung ano yung rhythm natin. So actually during compressions, yes, I agree, hindi pa siya ma-identify kasi nga we're doing compression. So the only time we can identify the rhythm is when we pause during rhythm identification.
So I have a question here sa YouTube, Doc, if it's okay to ask a few more. Okay lang, Doc. Sulitin ka na namin, ah. All right. So ang question here is, Doc Katie, which of these strategies are you already applying in your practice? And how is your experience with them?
So actually the modified Valsalva technique is one of the, I think, pinakasikat na strategies that is already being performed here. And I have also been able to perform that technique. So modified Valsalva actually is effective though. So that is, we can do that for patients that are hemodynamically stable. No? Hindi tayo nagmamadali. We can easily change the posture of the patient, and of course madali silang bigyan ng instructions. So, and then the rest actually hindi ko pa din sila na try, no, the head of CPR, the epinephrine drip, and of course the magnesium sulfate. I have also been able to give that to my patients.
Right. So I think that's all the questions we have sa YouTube and sa Zoom chat, not unless merong gustong humabol. Yung last question is mine, Doc Katie, kung okay lang. Right. So my question is, based on your review of the evidence, if you had to bet kung pupusta ka, which of these do you think will make it to the almost here, no, na 2025 guidelines, no, based on the strength of the evidence that you reviewed? Sa tingin mo, ano kaya dyan ang mag-make ng appearance sa 2025 AHA update for the
Okay.
ACLS?
Yes, I think the epinephrine drip, doc,
Mm,
it actually makes sense. Although I think based from my readings, and I've asked myself, bakit nga ba hindi siya usually pinapractice? I think
mm,
it's because of the logistics. Because the recommendation is to do central access, and then of course you have to have the pump to accurately give the medication.
yeah,
But I think epinephrine drip will be very beneficial. The use of epinephrine drip will be able to be included in the next AHA guideline.
all right. Okay, thank you so much once again, Doc Katie, for a very insightful and very well thought of discussion on these strategies. They're very interesting, and hopefully we get to apply them in our practice and improve patient outcomes. I'd also like to thank all our participants, both on Zoom and YouTube, for sharing your time with us in improving our knowledge base when it comes to resuscitation. And I hope our patients and ourselves are directly benefiting from this. So good morning again, everyone. We'll see you next month for the next R.E.M webinar series. Thank you again, Dr. Rodriguez. Have a
Thank you.
pleasant day, everyone. Thank you.